Hello, dear students and friends. Today, I would be speaking on a relatively newer topic. It is all about the role of ultrasound in management of labor. Till now, for acute emergencies, an ultrasound on floor in labor room was being used. We will see how now this ultrasound can be used to plot the sonopartogram in labor. So the topic is recent concepts in labor management through the Sonopartogram. Now, despite all major advances, the assessment of labor progress from digital vaginal examination has remained unchanged for at least a century. Today also, we rely on PV examinations, that is digital vaginal examinations, for assessing cervical dilatation, etc. Findings from digital vaginal examination are then regularly plotted manually on a partogram. This partogram helps in recognition of failure of labor progress and helps to guide management specific obstetric intervention. But in the last decade, the use of ultrasound in delivery room has increased because now we have more powerful portable ultrasound machines. Ultrasound was being used in intrapartum practice for acute management, like just after delivery of first twin, to ascertain the size of the second twin, to see its position, the position of head, and ultrasound was being regularly done. But an ultrasound-based partogram is a relatively newer concept. It is the sonopartogram and is an objective tool for graphical representation of labor. This demonstrates greater accuracy for ascertaining the fetal head position, for assessment of fetal head station, and is definitely complementary to our traditional clinical assessment. The details of my talk I've taken from American Journal of Obs and Gynae, and it would be reviewed under these following headings: historical aspect, the basic concept beyond sonopartogram, and details, evidence, whatever evidence we have for it, and summary. Coming to the historical aspect, Friedman labor curves were known from early 1950s. Then a graphical representation of labor from the general population was constructed, defining its normal length and duration. And this is what we have, a cervicogram. Labor progress was assessed using rectal examinations of cervix at that time, which were then recorded against time, and the curve which came was a sigmoid curve. In 1954, the first study demonstrated the value of plotting cervical dilatation against time. Now, with increasing developments in 1972, Philpott and Castle in Zimbabwe developed a partogram from this cervicograph, which provided a method for recording additional intrapartum observations like maternal parameters, fetal parameters, and not just cervical dilatation. In a further prospective study of 624 women undergoing labor, then came the alert line, beyond which some intervention would be required. The next stage was the introduction of an action line 4 hours to the right of alert line. Then in 1994, WHO recommended this partogram to define slow labor progress because there were lots of concerns associated with maternal and fetal morbidity. Regular digital vaginal examinations were undertaken to assess cervical dilatation, fetal head position, presence or absence of caput and molding, descent of head, color of amniotic fluid. In addition to that, maternal observations and fetal heart rate were also noted on the partogram. Since then, we've seen many changes to this original WHO partogram. As you can see, the first picture, this is a simplified partogram initially introduced. In 1994 came the Partograph by WHO, in which you can see the latent phase is still there. Then in 2000 came the modified partogram, in which the latent phase was abolished and it started with active stage of labor with 4 centimeters dilatation. Now we have the next generation partograph or the labor care guide by WHO in 2020. So in this emphasis on the second stage, in addition to the first stage, emphasis on the second stage is also given, and there are no action or alert lines, but parameters for alert are written over here. In the recent scenario, we do have an e-partogram, which is a modern one, in which it is all recorded on an electronic device, and continuous partograms of all patients in labor are there. And then there's always an alert, as it comes as a red alert when the normal parameters are exceeded. So now coming to the details of the Sonopartogram. The assessment of labor progress by intrapartum ultrasound was thought to play a major important role in management of labor and delivery. If you look at its historical review, in 1977, intrapartum ultrasound was used to assess fetal head descent. In this first known publication, ultrasonic echograph measured the distance from the fetal head to the tip of sacrum before and during labor, and this is how descent was measured. In addition to that, it also compared clinical evaluation of fetal head station. In 1996, Woskarinsky presented images of fetal head at different stages of labor by using a transperineal ultrasound. Now, the main concept is the sonographic analysis of labor progress is conceptually simple way of monitoring the key parameters of labor by ultrasound. Which parameters are to be measured? Cervical dilatation, fetal head descent, and fetal head position. If you look at the definition, the concept of comprehensive multi-parameter, non-intrusive ultrasound-based assessment of labor progress is known as the Sonopartogram, and it was first introduced in 2014. Now, if you look at this picture, on the left-hand side, we have the regular partograph, in which everything is plotted. But on the right-hand side, in addition to that, various parameters can be plotted through an ultrasound, like the presence of caput, molding, then dilatation of cervix, assessing the descent of fetal head, and fetal head rotation. First, let us look at evidence behind this concept. A prospective pilot study of 20 women in first stage of labor was carried out in 2 European maternity units. In addition to an ultrasound measurement of cervical dilatation, fetal head descent, and position, a simultaneous assessment was taken by digital vaginal examination also. So they had 52 paired ultrasound and digital vaginal examination assessments with a median of 3 per woman. In overall, 5% parameters on ultrasound were not obtained, compared with 18% from clinical examination. The assessment of cervical dilatation was possible in 86% of ultrasound examinations and 100% of vaginal examination, there being a high close correlation. Cervical dilatation by ultrasound was greater than by digital vaginal examination, and there was a difference of 1.16 centimeter. Fetal head descent was measured in these 52 cases by measuring the head perineum distance and a digital vaginal examination, but correlation between these two techniques was only moderate. Head position was obtainable in 98% of ultrasound examinations and only 46% of digital vaginal examinations, and there was a mean difference of 3.9. So their study concluded that Sonopartogram described a proof of a concept based on a combination of labor parameters derived from both conventional and examination and ultrasound. The data completeness was greater for ultrasound assessments than those based on clinical examination. So ultrasound was better for assessment. Ultrasound assessment of labor progress was found to be feasible in almost all cases. This technique described took no more than 5 minutes and was well tolerated by women. Now, if you look at the technique, the commonly used technique for assessing labor progress was a transabdominal ultrasound to assess fetal head position and a transperineal ultrasound to assess fetal head descent and the presence of Caput Succedaneum. First, how to measure the cervical dilatation. Transperineal ultrasound assessment of cervical dilatation can be done by 2D ultrasound, and this was first reported by Hassan. It was a novel and simple technique. In early stages of active labor before rupture of membranes, cervical dilatation can be seen and measured in its anterior-posterior plane by holding the transducer in transverse plane at the vaginal introitus and angling it gently up and down. This is feasible with fair agreement with vaginal examination, but attenuates at greater cervical dilatation. So at dilatation 7 centimeters or 8 centimeters or more, sometimes the lips of cervix are not that easily visible. Advanced cervical dilatations, the cervix is very thin, completely effaced, retracted, and the fetal head is low and maybe lower than the cervical ring. So the fetal head or the cranium can obscure ultrasound assessment. In such situations, fetal head descent can also be observed to track the progress of labor. So this is how, by placing the transducer transversely at the perineum, at the vaginal outlet. Here you can see measurement for 46 mm, 57 mm, and it is difficult after 7-8 centimeters, 79 mm. So the accuracy is more. Up to 0.6 mm, it was more accurate. So in 0.0 mm, like mm by millimeters, it is more accurate. Next parameter is assessment of fetal head descent, that is the station. Difficulty of identifying the ischial spines on ultrasound is high, and it is not possible to measure descent by the concerning ischial spines as we do in a vaginal examination. Here we measure the head perineum distance. For this, place the transducer transversely just above the posterior foreshead and measure the shortest distance from the transducer to the edge of fetal skull. So this is the head perineum distance, which reflects the perineum skull distance, and this too is measured in millimeters. Head perineum distance is not directly comparable with head station measured by digital vaginal examination. The coefficient of determination between ultrasound and vaginal examination for head descent has been reported, and this indicates that although there was a significant association between the two methods, the level of correlation was only moderate, because different methods are being employed in both of them. So this is how head perineum distance can be measured by placing the transducer at the posterior vaginal foreshead and the skull, the cranium. Distance between that and the cranium can be measured. Now the third measurement to be taken is the angle of progression. The ultrasound probe is placed transperineally in the sagittal plane. Angle of progression is the angle between a line through the long axis of pubic symphysis and the tangent to the fetal skull. This can be calculated either manually or automatically through the machine, depending on the type of machine used. As angle of progression increases, further is the descent of fetal head into the maternal pelvis during labor. So, higher the angle, better progress, better descent. Angle of progression has been found to be accurate and reproducible as a method of assessing descent of head in labor. Now, if you look at evidence, many studies have demonstrated an association among head perineum distance, angle of progression, and labor outcome in both first and second stages of labor. Egebo et al. Assessed the sonographic prediction of vaginal delivery in prolonged labor in 150 women in 2 centers. In their study, they found that when head perineum distance was 40 mm or angle of progression was 110, most women had a successful spontaneous vaginal delivery. But if it is head perineum distance was more than 40 mm or angle was less than 110, approximately half of the women had successful spontaneous vaginal delivery. So all did not deliver, only 50%. Transperineal ultrasound was carried out in their study by both midwives and doctors. So this is how you can measure the angle of progression. The next parameter, fetal head position, mainly to assess rotation of fetal head. Determining fetal head position is an important aspect of labor assessment, with malposition contributing to labor dystocia. A digital vaginal examination has significant limitations when determining fetal head position. At times, we are unable to find the sutures, or if there is caput, then we are unable to ascertain the exact position. Ackwell et al. Found that clinicians erroneously assign occipito-posterior position in almost 50% of cases. The assessment of fetal head position using transabdominal ultrasound is superior to digital vaginal examination, and ultrasonography has higher success rate than digital vaginal examination in determining the fetal head position. This is the only parameter which is done through a transabdominal scan. In the Sonopartogram study, fetal head rotation was determined on the basis of position of posterior fontanelle to the originally described 12-hour clock face with measurement rounded up or down to the nearest hour, in other words, 30-degree segments. Inter-observer and intra-observer variabilities of these techniques have suggested good agreement. So that is why they say that it is better than a vaginal examination. So this is how, by palpation of fontanelles, we do find out the position. Here in a transabdominal scan, this is how they can ascertain whether it is occiput anterior or occiput posterior. Occiput posterior by position of orbits, occiput anterior by identifying the thalamus and the midline, and left occipital transverse can easily be seen by presence of thalami in midline and cerebellum. Now, in a systematic review and meta-analysis, in nearly 3,370 women undergoing labor, this favored ultrasound in determining fetal head position in the first stage of labor. In addition to assessment of fetal head position, the fetal spine position also can be demonstrated with transabdominal ultrasound in the transverse plane at the level of 4-chamber view of heart. This supplementary additional ultrasound plane allows better understanding of fetal position. In the recent Green Top guideline by RCOG on assisted vaginal birth, they have recommended the use of intrapartum ultrasound for fetal head position whenever there is a clinical doubt. Now let us see how it helps in identifying Caput Succedaneum. This assessment of Caput Succedaneum is particularly subjective. It is described as a soft bulge of subcutaneous tissue which is felt as a swelling against the fetal skull, and its degree is not possible to quantify objectively from digital vaginal examination. Barbera et al. Demonstrated the identification of Caput Succedaneum using a transperineal ultrasound in sagittal view of fetal skull. Hassan et al. Compared the clinical assessment and ultrasound assessment of Caput in nulliparous women. This is an objective method of measuring Caput, and this is described by skin-skull distance, the distance between the skull and the skin. This was defined as maximum distance measured by ultrasound from the outer border of fetal skin to the outer border of leading arc of skull. Caput was measured in most cases and correlated with digital assessment. The repeatability of ultrasound measurement of Caput was good, and its presence was associated with CD. The presence of caput was associated with a cesarean delivery. So this is how transperineal ultrasound demonstrating caput and molding. Here, the distance between fetal skin and skull. This is the presence of a caput. And this is how you can see suture lines overlapping in case you want to see molding. Molding describes the change in fetal head shape occurring as a result of external compression forces on the cranial vault. It forms a part of vaginal assessment in labor. The first recognized ultrasound assessment of molding was in 1991. It can easily be visualized on sagittal view of fetal head using a transperineal ultrasound, in which you can see the skull bones overlapping and they can be measured too. Ultrasound can be used to classify the three different types of molding: occipitoparietal molding, frontoparietal, and parietoparietal molding. Occipitoparietal molding is seen most in occipito-anterior positions and is not associated with delivery mode, as it is likely a physiological process. Parieto-parietal molding is considered a warning sign for cephalopelvic disproportion. In a small study of 11 fetuses, frontoparietal molding was significantly associated with failed vacuum. Of the 11 fetuses with either frontoparietal or parieto-parietal molding, 10 underwent an operative delivery. So this is how molding can be identified. So to summarize, ultrasound is considered to be superior to vaginal examination in identification fetal head position. It is less evident that ultrasound is superior in identification of fetal head station and cervical dilatation, which is best assessed digitally in advanced labor. But in those cases in which you are in doubt, you can definitely do an ultrasound. Measuring fetal head descent by ultrasound is not analogous to clinical assessment of fetal head station developed by Friedman, and the latter using ischial spines and the leading bony part as reference points. The rate of longitudinal change in fetal head descent using head perineum distance and angle of progression as labor parameters have been described in assessment of normal labor progress examined sonographically, and they are effective. Let us look at the future. In future, the Intrapartum app based on Intrapartum prediction model would be useful. This app was developed in 2 European centers in 2015. It is the first obstetrical birth prediction model app created and allows on-the-spot analysis for prediction of vaginal birth using single maternal and ultrasound parameters. Prediction of labor outcome by using ultrasound in the second stage of labor is also in for future. This conveys objective and precise information on the relationship of fetal head concerning maternal structures. Dynamics of second stage of labor, that is head station, position, head direction, can be more accurately assessed than a digital vaginal examination. So it would prove very useful in the second stage specifically. It may predict the labor outcome whether instrument delivery should be attempted or if immediate cesarean delivery is preferred. This is another model, cesarean delivery risk assessment tool. So this would help assess the probability or the risk prediction score by using maternal demographic factors like BMI, height, combined with fetal biometry obtained by a transabdominal ultrasound. And this will tell us the probability of a cesarean delivery following a previous cesarean birth. Thank you. All other video lectures are on my YouTube channel. So please do subscribe and feel free to ask any questions. Thank you.